But when we talked about the renal tumor, it's the most common renal solid pediatric tumor. Its incidence is 8 per million of the children, and it's overall the 6 to 7% of the childhood cancers. More than 80% are diagnosed before the age of 5 years, and the median age is 3.5 years. Though in the familial tumors, it's a bit earlier age, like for around 1.8 to 2 years of age, they are diagnosed. It's common in both the, equally common in both the genders with some geographical variations. But the interesting thing is difference in the ethnicity. I mean, ethnic variability, and it's more common in the Black as compared to the Caucasian, and it's more common in the Caucasian as compared to the East Asian. And it's not because of the environment, because the study has been done in the USA, and they found this ethnic variability at the same environment having more in the Black than in the Caucasian than in the Asians. So basically, it's a more of a genetic thing or something related to the tumor itself, which causes this variability, and it's not because of the environmental factor, which is the cause in some of the adult urological tumors. The bilateral Wilms tumor are diagnosed in 5 to 10% of the cases. Now we talk about a little bit about the genetic of Wilms tumor. I understand that it's difficult to understand, but it's something which is very important in the Wilms tumor to understand a little bit about the genes, because nowadays what the treatment protocol are basically on these genetic tumors and the genetic and the biological markers. I'm not going into the bit detail, but a little bit of details of this. Basically, the Wilms tumor are of two types, sporadic and the familial, and the majority are the sporadic cases. And some syndrome are associated with the sporadic tumors, while the familial tumors are a small number, and when they are earlier age and they are bilateral, they are usually associated with the familial. And it's the familial Wilms tumor 1 and 2 is responsible for that. And I mean, you don't need to remember in your exams these chromosomes and all this. For the FWT1 and FWT2 is okay for that. This is some of the genes which are saying that what are the frequency of the percentages when the mutation of these lead into the Wilms tumor. But basically, this slide is very important, and which needs to understand that what are the few genes which are important in this tumor. First important is Wilms tumor 1 gene, which locates on the short arm of the chromosome 11 at point 13. And this is what causes the Wilms tumor, and it is associated with the syndromes. When there is a deletion of Wt1 gene, it leads to the Weger syndrome. And when there is a deletion, in absence of Wt1 gene, it leads to the Weger syndrome. But when there is a mutation of that gene, it leads to the Danish-Dress syndrome and some of the Fraser syndrome. We'll discuss in detail later bit about that Wt1. The second most common is the Wt2 genes, which is located at the short arm of the 11 chromosome with the 15 location. And the loss of imprinting of this Wt genes is associated with the common syndrome like organomegaly syndrome, most commonly the Beckwith-Widman syndrome. So one has to understand these, remember Wt1 and Wt2 genes. The third gene is at the X chromosome, which is a WTX gene, and it's most of the time associated with the mutation of Wt1 also. And the fourth is the P53, which is, we all know that the tumor suppressor gene, and the mutation of this leads to the, and a majority of the time it's associated with the anaplasia. So these four is most important to remember. Now, this is the thing which is in the red box is the most important, and nowadays in the National Wilms Tumor Protocol, this is the basically thing which they use in the management protocol to do the therapy, so that should minimize the toxicity of the chemotherapy for those tumors which are low risk from those which are the high risk and need the high risk chemotherapy. And how is it? When there is a loss of heterozygosity, the long arm of the 16 chromosome, and it leads to the increased risk of relapse. Similarly, when there is an LOH of the short arm of chromosome 1, it leads to the increased risk of relapse. So if somebody knows beforehand biological marker that this tumor, though it is a stage 1 tumor, but there is an LOH of 16q or LOH of 1p, it means there is a high risk of relapse, and these tumors should be treated with the high-risk chemotherapy rather than just having a stage 1 or a favorable histology or a low risk, whatever it is. So one has to remember that LOH 16q, LOH 1p, and the other thing is LOH of 11q, which is again also related to the increased risk of relapse. So these are the three things which you need to remember for exams and for the management of the child with the Wilms tumor. Now, there are some syndromes which are associated with the Wilms tumor. The one is the Weger, which I told you that it's a deletion of the Wt1, which leads to the Weger syndrome, which stands for the Wilms anaerodia, because the Wt1 having the near the P3 is a chromosome PAX6, which is responsible for the iris development, and if there is a deletion of that gene, it leads to the anaerodia. Wt1 gene is important for the kidney and the genital formation, so the deletion of the lead to the genital malformation and maybe have associated hypospadias or the undescended testes, and they can have a mental retardation. Here you can see the normal eye having an iris and the pupil, but when the anaerodia is there, it looks like this is the anaerodia which you see in the Weger syndrome. Second syndrome is the Dennis-Resch syndrome. Here is the mutation of Wt1. What does the mutation do? I mean, if there is a deletion, there is no gene formation, so there is an absent thing there. But if there is a mutation, it leads to the abnormal protein formation, abnormal DNA, which leads to the abnormal kidney. So there is a diffuse meningeal sclerosis, which causes proteinuria, nephrotic syndrome, and the end-stage renal disease. Associated with this is the pseudohermaphroditism or the ambiguous genitalia and the Wilms tumor. The third important is, Beckwith-Wiedemann syndrome, which is associated with the Wt gene and the loss of imprinting on the Wt2. And it's associated with the hemihypertrophy, macroglacia, you can see the hypertrophy of the lower limb. And it is associated with the hepatoblastoma, adrenal tumors, along with the Wilms tumor. When we talk about the clinical presentation of the Wilms tumors, most commonly it's presented as an abdominal mass. Sometimes it's a mass which causing the pain. Sometimes when the mom is giving the bath to the child, she felt a mass in the abdomen, so she got worried. Or sometimes mass is there, but child fell down on the ground or somewhere, or there is a fight in the school and they have a pain, and then at that time the mother noticed there is an abdominal mass. So the most common presentation is with this. 20% have an associated hematuria, 10% have associated constitutional symptoms like anorexia, vomiting, and the malaise, and 20 to 25% have associated hypertension. So these are the things which we need to ask in the history if only somebody comes with the abdominal mass. We need to ask all these things in the history along with the other details in the history, and also, of course, the family history is very important. Now the examination. Head-to-toe examination is very important to identify some syndrome if it's associated with this mass. For example, when the child's come and you start talking to him or her, you can identify that the IQ level is fine or not, is there any mental retardation or not. Then the general physical examination will tell you presence of anemia, the hypertension by measuring the BP, you can identify. And when you start examining from head to toe, you can identify if there is an anaerodia or not, if there is a macroglacia or glossia or not. Is there any other visceromegaly? Is there an omphalocele? Is there a genital anomaly or an undescended testes? So this how you can never miss any associated syndromes or any features which can identify the associated syndromes. So that's why it's important. I mean, anyway, it's very important in every patient, but this is particularly important Wilms tumor to look for these things when you start examining from head to toe. Now, how to diagnose? The child came with the palpable mass or some symptoms, and you asked you did the history and examination. So after the laboratory investigation, the ultrasound is the first important investigation, which will tell you about the mass, whether it's a cystic mass or the solid mass. Then the Doppler of that mass. Flow is there or not? What is the relationship with the kidney? Is it occupying the whole kidney or is just some pole of the kidney? Along with this, it's an important tool to give you idea about the IVC. Is there an association IVC thrombus or not? Because most of the time in CT, you cannot pick up the IVC thrombus because the huge mass is compressing the IVC. But the ultrasound with the Doppler is a very good tool to identify this. Along with this, in CT scan, sometimes it's said that, okay, there is a loss of fat plane between the kid mass and the liver or mass and the spleen. The ultrasound gives you a good idea about the association of the mass with the liver or a spleen, because when the child breathes and you do the ultrasound, you can see the very good movement between the kidney and the solid organ like a liver or a spleen, and this can give you the idea that there is a loss of fat plane or there is a plane between these two organs. CT scan is needed, and it should be CT scan chest and abdomen, and it should be triphasic. Of course, we cannot compromise on the details of these, because arterial phase give you an idea about the arteries, and the venous phase will give you idea about IVC thrombus, association choroidal vessels are there or not, and in excretion phase, it can give the details about the ureter, because sometimes the tumor can extend into the pelvis, in the ureter, or down into the bladder. So all these three phases are important. Venous tumor have a tendency to spread into the chest, and the liver. These are the two most common site of the metastasis. So CT chest is also important, and here you can see that there is a tiny metastasis is present in the CT chest. Again, it can give you the idea about the anatomy. Like, for example, if this is a horseshoe kidney, it's a right moiety, this is a left moiety, and you can very well see the arterial supply and the tumor in between the two moiety at the level of the isthmus. In this, you can very well identify the thrombus in the IVC, and this is a coronal image which can give you the details about the IVC thrombus. Some few investigation the people do sometimes for the IVC thrombus, they prefer to do the MRI, but if there is a good CT scan, they can give you idea about the thrombus, it can give you idea about the liver metastasis or some other metastasis or the chest metastasis. The isotope scan, if it's a bilateral tumor or if it's a unilateral small tumor and you are planning for the nephron sparing surgery, then the isotope scan does a very important job. Now comes the management of the Wilms tumor. Remember one thing, oncology is not a one person's job. It is always a multidisciplinary teamwork. The surgeon cannot work independently, and it should not work independently or should not work in isolation. It should be in combination of the radiologist, pathologist, radiotherapist, oncologist, and the geneticist. And it should be always in a multidisciplinary way, and all the tumors should be discussed in the multidisciplinary tumor board meeting for their management plan. That's how all the tumors to be dealt. Now we have diagnosed the child with the mass, presentation by mass, and an ultrasound it found to be the solid tumor involving the IVC or a solid tumor without any metastasis. Now what should we do? So in this, there is a two management arm. The one is known as the National Wilms Tumor Group Study, which is now known as the COG, which is the Children Oncology Group. They do the upfront surgery, like the renal tumor is there, they do the surgery, surgical excision, and then followed by the chemotherapy and radiotherapy. Though in some cases they give the pre-op chemotherapy, like for example, if there is an IVC thrombus which is extending above the hepatic veins, if there are the bilateral tumors and the nephron sparing surgery is not possible, or if the tumor is so large that the morbidity risk is high, that is the high chance of the spillage, or there is a patient condition is not allowing for this high risk surgery. So they give the pre-op chemo only on those cases. The other management arm is a SIOP, Society of International Oncology Pediatrics. They give the new adjuvant chemotherapy, followed by the surgery, and on the basis of staging at the risk group, they give the further chemotherapy and the radiotherapy. If you look at the overall survival in both the groups, it's equally more than 90% in the low stage tumor and the 80% in the high stage tumor. It's basically the different approach in the different part. NWTS in the American people usually use it, and the SIOP is usually the European people use it. Here in Karachi, at SIUT, we usually follow the SIOP protocol along with our oncologist, Dr. Shamal. And when there are the two arm and the two management, each has its own advantages and disadvantages. First, we talk about the COG protocol. The advantages is that it gives you the accurate histology because it's not been touched by the chemotherapy. So whatever the components are present in the tumor, it can give you the idea that what components are there. It can differentiate between the benign versus malignant. So the unnecessary chemotherapy can be avoided by getting the exact pathology in hand. And of course, it can give you the accurate stage because they are not touched. So it can give you an idea whether it's a stage 2, stage 3, or the nodal involvement is there or not. But the disadvantage is that there is increased risk of surgical complications. If the tumor is large, there is increased risk of spillage, there is increased risk of incomplete excision. And sometimes if it's a very large tumor and it can miss the lymph node, so the lymph node sampling is not possible. When we talk about the SIO, the advantages are there are few surgical complications. Of course, because you give the chemotherapy, you reduce the size, and now it's more solid, more confined, and it's easy to trick it out. But of course, not in all the cases. There is a low incidence of the tumor rupture, and you can assess the tumor response also, because if you give it a pre-op chemo, you know that this tumor is a chemo responsive or not. And it can downstage the patient. And sometimes in a unilateral case, it's possible to do the nephron sparing surgery if it's a small tumor and it's decrease in size, and if nephron sparing surgery is possible. But of course, SIOP has some indications for the nephron sparing surgery. But having the sub disadvantages also. Modification of the tumor histology because the blastema responds to the chemotherapy, so it's only majority of the time just the stroma or the epithelial component left, or it gives the loss of staging information. Sometimes the chemotherapy is given in the benign disease because you don't know, you just on the basis of CT scan gave the chemotherapy. Or it may not be a Wilms tumor, it can be a different tumor which received the chemotherapy. So to address these last two disadvantages, that chemotherapy to the benign disease and chemotherapy to a different malignant tumor, there are two options. The UK version do the pre-chemo biopsy of these tumors, whereas the international version of the SIOP, they don't go for a biopsy. So by doing the biopsy, you can identify that is it the benign disease or a malignant, and if it's a malignant, whether it's a Wilms or some other malignant tumor which needs the chemotherapy according to their pathology. So when we talk about the biopsy, whether we should do biopsy or no biopsy, previous NWTS classification and the staging says that they tumor biopsy upgrade the tumor, but it's not for the needle biopsy, it's for the open biopsy. Biopsy yield is very good. Biological marker can be done. You can identify what are the component of this tumor, and there are very rare complications. What you get in the biopsy? In the biopsy, the Wilms tumor is basically, as we know, that the immature embryological tumor, it develops into the three components. The blastemal component into the small round blue cells, the epithelial component in the form of the primitive tubules, and the stroma in the form of cylindrical cells. So the classical Wilms tumor have all these three component, epithelial, stromal, and the blastemal. However, the Wilms tumor can be biphasic, having just two components, or monophasic, having one component. Sometimes if they are only the one component, like if, for example, it's a blastemal component, then it's a very difficult task because it's just around a small blue cell tumor. Then we need to have a tumor marker to differentiate between the, whether it's a PNAT, whether it's another tumor, whether it's a Wilms tumor or what. And it also gives you the idea about the presence or absence of the anaplasia. And this will give you the idea about the planning the surgery further after the chemotherapy. Now, if we are planning to give the new adjuvant chemotherapy, for example, if we are following the SIOP protocol, we did the biopsy, it turned out to be a Wilms tumor. And the staging workup shows a localized disease, there is no metastasis, then it needs just the 2 drugs for 4 weeks and then the reassessment CT. But if there is a metastasis in the liver and the chest or any one of them, then they need a 6 weeks chemotherapy and the 3 drugs, including the actinomycin, vincristine, and doxorubicin. Remember, the doxorubicin having a cardiomyopathy risk, so one should have an echocardiogram before giving the doxorubicin. There are some special situations like a bilateral tumors or the tumors in the solitary kidney or the horseshoe kidney where the oncologist can modify the chemotherapy accordingly, to see that whether the nephron sparing surgery is possible or not. So this is what you see, that it's a pre-op, pre-chemo CT, and it's a post-chemo, and there is a significant reduction in the mass and a significant reduction in the enhancement also. Now, where comes the role of a surgeon? Before the surgery, the surgeon must know the extent of the tumor. Not only the extent of the tumor before surgery, but what was it like before the chemotherapy also. What was its location within the kidney at the time of the surgery and before starting the chemotherapy. Its relationship with the surrounding vessels, surrounding large like vessels, superior mesenteric, celiac, and then inferior mesenteric, aorta, and IVC, and the surrounding solid organs also. The enlarged intra-abdominal lymph node should be known to the surgeon before going in by the CT scan. Sometimes, of course, it's difficult, but if clearly we see the CT scan, of course, the pre-chemo CT scan is very important to identify those enlarged lymph nodes, and post-chemo also help in identify those lymph nodes. And of course, last but not the least is the thrombus in the renal vein and IVC. If there is a thrombus in the IVC, then important thing to see that whether it's a complete block of the IVC or there is some flow in the IVC to identify whether it's a floating thrombus or is the thrombus adherent to the wall of the IVC. And if it's a complete block, then one must see is there any collateral supply to the kidney or not. And it's easy on the left side because on the left side, you can get the collateral supply from the adrenal and from the gonadal vessels, but it's tricky in the right side when the azygos and the hemiazygos dilate if there is a complete block of the IVC. And these, all the things surgeon should know before operating on the tumor patient. Surgery comes is usually the transabdominal approach. You can't do it with the flank approach because it's difficult to approach go to the aorta, IVC, and the lymph node sampling is difficult with the flank, so it should be on the transabdominal. That's what the SIO protocol says, and we have to follow that. Once you are inside the abdomen, you have to do the survey. Now the CT is so advanced that we can identify most of the things, but the peritoneal seedling is usually identified on the exploration of the abdominal cavity. Sometimes the laparoscopic surgery is possible, but it's not still in any protocol, though the people are doing at different centers the laparoscopic surgery for the unilateral and even for the bilateral Wilms tumor, but it's not any protocol to go for the laparoscopic surgery. The early ligation of the vessel, as in all the tumor surgery, is the protocol that we should early ligate the vessels first and then they do the tumor mobilization and the excision of the ureter as down as possible. Here it's one important thing. The moment you see the ureter, you should apply the clip first so that there should be no the tumor seedling down into the ureter or the bladder, because we saw one of our case having the metastasis in the bladder after 5 years of the treatment. And there, the hypothesis is created there may be a tumor seedling during the mobilization of the tumor and all these things. So we now usually clip the ureter as soon as we see the ureter down. And we should remove the tumor with the surrounding adipose capsule. And the important thing one should know that there should be no heroic or the multi-mutilating surgery is recommended in the tumor surgery. Adrenal gland can be left inside too if the safe resection margin is present. But if there is no safe resection margin, you can just take out the adrenal with the tumor. As I've mentioned that the thrombus, you have to palpate the thrombus in the vein and the IVC. Then you have to identify, and if such thing, it's better to have a vascular surgeon along with, the surgeon can do it, but it's better to have a vascular surgeon around in case any unforeseen things come in during the surgery. We should have support with us. And as I've mentioned that if it's a complete block on the IVC and there is no flow, and mainly if it's at the right side, then it's easy to take it out with the ligation of the renal vein. If you have seen the collateral are good before the surgery on the CT scan. But on the left side, it's a bit tricky because if it's a left side tumor and if you are taking it out, then leaving the right side and ligating the right side, it's a bit risky. So one has to be very sure about the collateral vessels before embarking on the excision of IVC. As far as the lymph node documentation is concerned, in the Wilms tumor, there is no need of radical lymph node excision like in other tumor. You just need to have a sampling of that. And though there is no standard protocol that how many lymph nodes, but the study have been done by the umbrella group and the other groups. And what they found that as the number of lymph node increases, the chances of identifying the stage positive lymph node are increased till the number 7. When the 7 lymph nodes were there, it was reached to the plateau level of identifying the positive lymph node, whatever the number above the 7 lymph nodes. So it's said that it should be sample at least 7 logo-regional lymph nodes. Hilar and the para-aortic lymph nodes should be sampled even if they are not suspicious. But unnecessary dissection of other lymph nodes should be avoided to avoid the further complication. If after the chemotherapy there is a necrotic lymph node, it should be considered as a positive lymph node and it can upstage the tumor. This is the umbrella protocol now, as the NWT is combined with the COG and the children oncology for the Wilms tumor and the renal tumor, SIOP having the renal tumor study group, and other European countries including the SIOP with the RTSG group, and they are covered under the name of umbrella, which are dealing with all the renal tumors. When we talk about the nephron-sparing surgery, it's contraindicated in the following condition in the SIOP protocol: when there is a pre-op tumor rupture, when there is an infiltrating extrarenal structures or intra-abdominal metastasis or lymph nodes, when there is a thrombus in the IVC or the renal vein or the multifocal tumor, or when there is a presence of anaplasia or biopsy on the biopsy. While there are a few indications of doing the nephron-sparing surgery in the SIOP. For example, in the bilateral tumor, of course, we have to do the nephron-sparing surgery if it is a solitary kidney, in the rare cases of horseshoe kidney. When there is a renal dysfunction, like in the Danish dress and the Fraser syndrome, or in other causes of the renal insufficiency. Whereas the umbrella protocol say that even in the unilateral tumor, you can go for a nephron-sparing surgery if the small tumor volume of less than 300 mils, and if you expect that the tumor residual functional tumor will be more than 50% of the kidney, then you can do the nephron-sparing surgery. But there should be no lymph node positive before the surgical chemotherapy, before the surgery CT scan. Now we have done the surgery, we have done the excised the tumor, we have taken out the lymph node sampling has been done. What to do the next? Of course, it comes the staging, and of course, according to the staging, the chemotherapy and the radiotherapy. When we come to the staging in the in the NWTS and the SIOP, both have some risk group stratification for the chemo and radiotherapy. So in histology, for the SIOP, we need to see the percentage of the necrosis and what are the percentage of the other component, that are what are the percentage of the blastema, stroma, and epithelial. Whereas for the NWTS, we want to know whether there is any aplasia or not. So like, for example, if you have seen the histology and it shows the percentage of the necrosis, because it's very important, the histopathology should know all these things and it should be classified according to this, and it will help us in further chemotherapy and the radiotherapy. So the percentage of necrosis is 100%, it leads to the complete necrosis. If it's a 66 to 99%, it's a regressive type, and if it's less than 66%, then you have to see which is the more common, more than 50% of this. Like, for example, if it's a 50% blastema, then it will be labeled as blastema. If it's more than 50% stroma, then the stromal. If more than 50% epithelial, then it's the epithelial tumor. And when it's a different combination of all the three components, then it will be labeled as a mixed. Along with this, you have to see that is there any aplasia or not. On this basis, you give them a risk stratification. For the 100% complete necrosis, it will be the low risk. For the blastemal component and the aplasia, it will be a high risk. And for the rest of the tumor, that is the stromal, mixed, epithelial, and the regressive type, it will come into the intermediate risk group of the SIOP protocol. Whereas if we see in the NWTS, it's just a favorable and unfavorable group, and all the other tumors like triphasic, epithelial, stromal, blastemal, it comes in the favorable histology. When there is an aplasia, whether it's a diffuse or focal, it comes into the unfavorable histology group. Here you can see that in the SIOP, the blastema comes into the high risk tumor because blastema component is the most sensitive to the chemotherapy. And even after the new adjuvant chemotherapy, it's showing the highest part of the blastemal tumor. It means that this tumor is not that much chemosensitive, or that chemotherapy is not affecting on this tumor, and they need to be placed into the high risk tumor group. Now, as I've mentioned in the earlier slide, that why it is important to focus on the genes and the chromosomes, because recently most of the biological markers are acting as a prognostic factor for the chemotherapy and the radiotherapy. The important is LOH at chromosome 1p and the 16q. An increased number of the chromosome 1q, it's again lead to the unfavorable prognosis. High count of the DNA index of more than 1.5 is again a poor outcome. And the higher age is lead to the increased risk of recurrence. So this is how we stage the Wilms tumor. I know this is very busy slide and it's difficult, but just to show you that how it is staged in the NWTS and into the SIOP. But just to simplify them, you have to remember that it's a stage 1 when it's inside the capsule and the completely excised. If it pierces the capsule, but it's inside the adjacent tissue and the adipose tissue and completely excised. There is tumor is not reaching up to the resection margin. It is stage 2. Stage 3, if there is a microscopic or macroscopic residual tumor is there, or if there is a tumor spillage, local spillage, or the diffuse in the abdominal spillage, because if it is a diffuse spillage into the abdominal cavity, then it's upgrade the stage 3 to stage 3B. And along with that, the presence of the lymph node also give you the stage 3, or the IVC thrombus is also included in the stage 3. Stage 4, when along with this there is a distance metastasis into the lung or a liver, and the stage 5 is a bilateral Wilms tumor. In the bilateral Wilms tumor, bilateral are known as the stage 5, and after the surgery, we individual tumor are classified according to the local staging into the 1, 2, or 3. So the COG risk stratification involves the stage, that is the initially NWTST, now that's in general oncology, the stage of the tumor, what is stage, it's 1 to 3, the histology, whether it's favorable or unfavorable, what is the age, less than 1 is considered to be the favorable age, what is the tumor weight, less than 550 grams is considered to be the favorable prognostic marker, and the LOH at chromosome 1p and 16q is considered to be the poor prognostic marker because there is an increased risk of recurrence. Whereas the SIOP or the umbrella RTSG renal tumor staging group use the residual blastomal component in the high risk and the markers for the further chemotherapy into this tumor. I'm not going into the detail of these chemotherapy, but just to show you that how these SIOP and all these are chemo protocols are made. And nobody can remember all these protocol by their heart, but they have all these available in their hand. So after the surgery, we have a staging, we have a risk group, and with this, we can give the chemotherapy, whether it's a stage 1, low risk, intermediate risk, high risk, and what are the chemotherapy and the radiotherapy according to that protocol. Similarly, the radiotherapy, how the radiotherapy in the children oncology group are given in the stage 1, 2, 3, favorable histology, focal aneuploidia, and diffuse aneuploidia, similarly in the metastatic disease. And similarly in the SIOP protocol, these all other tables are made and one has to just follow according to what stage, what is the risk group, what is the stage, and then we can give the treatment according to this. Now come the bilateral Wilms tumor. This is a bit tricky. And of course, this is a difficult tumor to manage because majority of the time in here the tumor comes in the later stage and they are the huge large bilateral Wilms tumor, and sometimes it's difficult to do the nephron sparing surgeries. Count for around 5 to 7% of the children having the bilateral synchronous tumor, having the tumor on both the kidneys simultaneously. Sometimes they have a metachronous Wilms tumor. One tumor operated, you did the radical nephrectomy of the one side, and after 6 months, a year or 2 years, the metachronous tumor appears into the contralateral kidney. In the important thing that they should not, if there is a synchronous bilateral, they should not go under the radical nephrectomy straightforward, because the purpose is to do as much as is nephron sparing as possible. So the kidney with the lower tumor burden should be addressed first, but in case if it needed to bilateral nephrectomy, then at the time of surgery, the native renal tumor tissue should be taken out to prevent the tumor recurrence once the patient receives the immunosuppression. So the pre-chemo purpose is to do the tumor reduction till it's possible to do this nephron sparing surgery. We should start with the 2 drugs, but if it's not responding, we can give it to the 3 drug or a high risk chemo depending on the oncologist, because of course it's always a multidisciplinary approach. And the parents should also be taken into the consideration and on board with every change in the management, and we need to have a discussion with them all this thing. We have to do the partial nephrectomy on one side, and once it's settled, then we can go for the partial nephrectomy. But if the partial nephrectomy is possible, both the sides simultaneously, we can go for the partial nephrectomy on both the sides simultaneously also. Now, you have done the job, you have taken out the tumor, you have done the chemotherapy, radiotherapy, and the patient is now off treatment. How to follow them? You have to follow them, and in each follow of them, you need to see the growth of the child. We need to see the general well-being, and it's good to have a combined clinic with the oncologist and the surgeon so they can both see these children together. We have to measure the blood pressure at each visit, because sometimes if they were hypertension before the surgery because of either the renin secretion or because of the tumor pressure on the other vessels, they can have a low pressure, or they can have a persistent hyperpressure because of the permanent pathology. So we need to check the blood pressure on each visit, because now they are left with the one kidney. So we need to take that one kidney. We have to do the ultrasound abdomen on each visit to see any tumor growth, recurrence or relapse. They should have a chest X-ray which can identify the tumor metastasis in the chest, liver, lung mets. And if there is a normal renal function, we should have a serum creatinine once a year. But in case of the renal dysfunction, we should have a creatinine and the electrolytes 3 monthly. And one should have a once a year urine DR for the protein urea to see, because now it's the only kidney left, and we have to prevent the hyperinfiltration injury to that kidney. The follow-up protocol should be 3 monthly for the first 2 years, 4 monthly for the next 2 years, 6 monthly for the 5th year, and then yearly till the 10 to 14 years post-treatment, because we have seen the recurrence are there. Most of the recurrence, 80-90%, are in the initial 2 years of the follow-up. But sometimes there are few tumors which relapse after 3 years, 10 years. As I've mentioned, that one of our Wilms tumor relapsed in the bladder after 5 years post-chemotherapy and post-treatment. When the relapse is there, what to do? It's again the same what we have done with the the initial tumor. We have to do the baseline labs, ultrasound to see what is the tumor extent, then the CT scan with the chest and abdomen and all the details of the CT scan. And if it's a biopsy should be done to see whether it's the same tumor or it's another different tumor. And the chemotherapy or surgery, if it's a resectable, one should go for the surgery upfront in this, but it's not, then I have a chemotherapy protocol are there for the relapse cancers, relapse Wilms tumor. Now comes the other renal tumors. As I've already mentioned, just a brief overview of these. One is the clear cell sarcoma of the kidney, and it is the very lethal tumor, but it's account for only 3% of the tumor, and there is no standard protocol for their guidelines. PSYOP include the clear cell sarcoma into the high-risk group, and they treat them as a high-risk tumor. There are the predictor of improved survival if there are lower stage at the diagnosis, if the patient is young at the time of diagnosis, and if there is any absence of necrosis. They have the potential to metastasize to the brain and the bone. So one in the biopsy, two-gut biopsy, you identify that it's the clear cell sarcoma. One should have a bone scan and the scan of the brain to identify the metastasis. There is an increased risk of relapse in this clear cell sarcoma, and some have a potential to relapse even after the 10 years. So they need a very close follow-up. Rhabdoid tumor of the kidney is the most lethal childhood tumor. There is no treatment available, non-responsive to the tumor. So if infant comes with a renal tumor which is not responding to any therapy, then the highest chances is the rhabdoid tumor of the kidney. And there is no standard therapy for this tumor. Congenital mesoblastic nephroma. This is the most common infant tumor. So when the child comes with the antenatal history of a mass in the kidney, or a child before the 6 months of age come, usually the PSYOP, even the UK version, don't go for a biopsy, because they prefer to do the upfront nephrectomy in the children less than 6 years, because having a high chances of having a mesoblastic nephroma, which can be a benign variant. If the surgery is not possible or it's risky, then you can go for a biopsy with all the risk and benefits explained to the parents. And you should also in your mind that what are the risks of going to the biopsy, risk and benefit, and then go for a biopsy. So the most common tumor in the infants, and mean age of presentation is 3.5 months. There are the 3 types of this tumor: classical, cellular, and the mixed. Classical is the most benign one, and the cellular is the malignant variety. There is no such chemotherapy available for that, and the surgical excision is the only cure. But sometimes if there is a relapse or the recurrence after this, which is majority of the time after the cellular tumor, then you need to have a chemotherapy for that adjuvant treatment for that relapse or the recurrence. Very briefly about the neuroblastoma. I think I'm running out of the time. Yes, no, I have a few minutes left. Neuroblastoma. I'm covering the neuroblastoma here because when the children come with the abdominal tumor, sometimes it's difficult to differentiate between the kidney tumor, whether it's a Wilms tumor or neuroblastoma, if it's completely encasing the kidney, or if it's arising from the kidney. So what is the neuroblastoma? And as I've mentioned, it's the most common extracranial solid abdominal tumor of the childhood. After that is the Wilms tumor, and it's arise from the cells of the neural crest, which are present in the adrenal medulla and into the sympathetic bone. And the 75% of the neuroblastoma arise in the retroperitoneum, of which 50% is from the adrenal and the 25% into the paravertebral ganglia. And the tumor has a tendency that it can spontaneously regress, or it can differentiate into the benign neoplasm like a ganglioneuroma, or it can exhibit the extremely malignant behavior. So neuroblastoma is completely haphazard tumor which can turn into anything. And it's 8 to 10% of all the childhood cancer, and it's occur in the 10 per million of the live birth, and it's the most common malignant tumor of the infancy. But the median age the diagnosis is the 19 months. But those who are diagnosed on the screening or in the prenatal life, screening via the VMA level, they have the good prognosis and they have a tendency to resolve or spontaneously resolve itself. Neuroblastoma is the first malignancy in which the prognostic marker were identified, the biological marker, and the treatment of the tumor is dependent not only on the stage and the histology, but also on the biological marker. After that, it comes into the Wilms tumor to identify the biological marker and to give the chemotherapy and the radiotherapy according to that. The markers in the neuroblastoma which are favorable are the DNA aneuploidy, and if there is a tetraploidy, it leads to the poor prognosis. And the adverse markers, prognostic marker, is the NMYC gene, which is very important to identify. We are doing it, the NMYC amplification in the neuroblastoma. If the amplification of NMYC is positive, it means it's a poor prognostic sign. Similarly, if there is a deletion of short arm of the chromosome 1 or the long arm of the chromosome 11q, then there is an increased risk of recurrence, relapse, or the poor prognosis. As I've mentioned, the neuroblastoma can turn into anything. There is a spectrum starting from a neuroblastoma at one corner, which is the most malignant, and a ganglioneuroma at another corner, which is the most benign, and the ganglioneuroblastoma in between, which can have a malignant and the benign potential both. The histology for the neuroblastoma is identified in 1984 by the Shimada, which is, and it's not actually, it's basically histopathologist's job, but being a pediatric urologist, one should know that a little bit of detail about these classification also. So Shimada divide into the stroma rich and the stroma poor, and the stroma poor can again divide into the favorable and the unfavorable prognostic marker. And in stroma rich, if it's a nodular, then it's a poor prognosis with the neuroblastoma. But in case of the intermix and the well differentiated, it can lead into the ganglioneuroma or ganglioneuroblastoma, which are the favorable things. This is a picture of the Shimada classification. Here you can see there is no stroma, just a round small blue cell tumor, stroma poor. And here you can see the stroma rich. All of this is a stroma, so it's a good prognostic sign. They can present like in the Wilms tumor as a mass with the pain, but they have a tendency to majority, 70% are present with the metastasis. So they can have a symptom because of a METS, bone or joint pain. As I've mentioned, they can arise from the paravertebral ganglion, so they can proceed into the spinal canal, lead to the spinal cord compression. They can arise from the spinal cord in the area of the sacrum, where it can lead to the urinary bladder compression, gut compression, lead to the urinary retention and the constipation. Or they can have a paraneoplastic syndrome because they secrete the catecholamines, which can lead to the pheochromocytoma-like symptoms like hypertension, palpitation, or can have a secretion of VIP, which can lead to the watery diarrhea, or can have a myoclonic encephalopathy. These all are present with abdominal mass and these symptoms. Lab investigation, of course, baseline labs, along with that urinary VMA and the HVA are the diagnostic marker, which are positive in 90 to 95% of the neuroblastoma patients. Investigation, ultrasound, again, the tumor identification will give you the CT scan. The recent COG protocols wants to have a MIBG scan in all the children with the neuroblastoma, and they don't go for a bone scan. But here in Pakistan, we still go for the bone scan for the neuroblastoma. They should have a bone marrow aspiration and biopsy. And remember, the biopsy is important. It's not only the aspiration which is needed in the neuroblastoma, and it should be from the two sides too, for the better identification of the involvement of the bone marrow. And the PET scan are sometimes needed if we cannot identify the site of the metastasis. The difference between the Wilms tumor and the neuroblastoma, here you can see the kidney is pushed on the one side with the central tumor. There is a little bit of calcification in this tumor, which is a prognostic, which is a marker of the neuroblastoma. It is encasing the larger vessel, which is again the marker for the neuroblastoma as compared to the Wilms tumor. And here you can see in the pelvis, this is a mass which is displaying the aortic bifurcation. The stage of the disease, international neuroblastoma staging score is difficult to understand in this. So here you can see if it's a bilateral tumor with negative lymph node, stage 1 ipsilateral, but complete resection is not possible. Then stage 2 ipsilateral tumor with ipsilateral lymph node, stage 3 2B. And depending on the lymph node and the site, if it's a midline, it can be stage 3. Metastasis is present in stage 4. One important thing in neuroblastoma is stage 4S. S stands for the special. When there is a tumor with involvement of child age is less than 1 year, metastasis to the liver, skin, or the bone marrow with the tumor, then at least in name is a stage 4S, and usually they have a good prognosis and can lead to the spontaneous resolution in some cases if there are not the poor prognostic marker. We do the risk stratification, and the neuroblastoma do the risk stratification on the basis of the CT scan when they found the radiological factors and divide them into the L1 and L2, that these are not a good marker to go for a surgery in these cases. And here they can divide, of course nobody can remember all these in details, but how they divide into the L1, L2, and for the metastasis and according to the age, that is less than 18 months or the more than 18 months, because here in this 18 months is the prognostic marker. So by this, they divide them into the low, intermediate, and high risk, and you can see that it's depend upon the stage, the age of the child less than 1 year or the more than 1 year, and mixed status amplification is a poor prognostic marker, DNA index is more than 1.5 is a poor prognostic marker. The Shimada histology, that is a favorable or unfavorable, then it's, if unfavorable, then it's a poor prognostic marker. Along with that, if its age is less than 1 year, it's a good prognostic marker. Adrenal having the poor prognostic marker as compared to the other abdominal part. And if it's a stage 4S, then it's a S-min special and they have a good prognostic marker. Poor outcome can occur into the stage 4S if there is an elevated neuron-specific enolase or a high ferritin level, or there is an MIC amplification. Treatment is again the same: surgery, chemotherapy, and radiation therapy. And believe me, it's very difficult to manage the neuroblastoma if they are crossing the midline or encasing the major vessels, and they should be decided into the tumor board meeting that what are we going to achieve with this surgery, along with the staging, high risk group, and what are we doing with this. But one thing important one has to remember, that surgery of the neuroblastoma, one should not sacrifice the vital structure to achieve the resection, complete resection in this. The goal should be to establish the diagnosis, to stage the tumor, and if it's localized, to excise it. A lot of chemotherapy is available, including the multi-agent treatment regime. Intensive induction lead to the myoablation, consolidation, and the biological therapy and the bone stem cells. Support is needed along with the myoablative consolidation, but they have a lot of immunosuppression in this, and usually the children cannot survive these sort of chemotherapy, and where there are very little availability in the Pakistan. Radiotherapy is there, and they are usually effective for the local control in the advanced stage 4 or the bulky stage 3, and sometime in the intraoperative radiation therapy. So with this, I conclude that, of course, it's Wilms tumor is a curable in majority, and in the pediatric uro-oncology is always, and all the oncology is a multimodality. It should be include the pediatric oncologist, radiologist, geneticist, and one should adhere to the standard protocol. In a developing country where it's difficult and usually present late with a large tumor, one has to go for the PSYOP if they can, with the biopsy and the chemotherapy, reduce the size of the tumor and then do the surgery. And there may be the subgroup, as I've mentioned, with the biological marker, when you can do the chemotherapy according to that biological marker. Thank you. Now, if anyone has some question, they can ask me a question. I can see the chat box also if there is some question. What is the first line treatment? Wilm stage. What is this question? Is by the Javeria Kamar has asked, should we decide lymph node involvement before nephron sparing surgery on the basis on CT scan or with the frozen section? No. The Javeria lymph node, if they are large, more than 1 centimeter on the CT scan, it means they are involved by the tumor. And in this case, if it's a unilateral tumor, you don't go for the nephron sparing surgery in these tumors. So on the basis of this, yes, in the bilateral cases, you have to do the nephron sparing, but the CT scan suggests you if they are more than 1 centimeter. The second question is by the, I don't know the name, who is Huawei. What is the first line treatment Wilm stage with thrombus in IVC? What is the first line treatment Wilm stage 3 and thrombus? The first line treatment, as we are following the SIOP protocol in the stage 3 and the thrombus in IVC is usually again 2 drugs. Sometimes it depends on the oncologist, they modify the chemotherapy accordingly, and after that, sometimes they give the 6 weeks, the 3 drugs, and you assess the tumor response on the surgery, on the CT scan. If it's resectable and sometimes the tumor thrombus is extending up into the atrium, then you need to have a cardiothoracic surgeon and the bypass available to take out the complete excision of the tumor. A basic question, how is neuroblastoma and pheochromocytoma different? Both involve adrenal medulla and have some metabolites. Yeah, sometimes it's difficult, but usually pheochromocytoma, they don't appear like the neuroblastoma, that they're usually at presentation are the large tumor, neuroblastoma encasing the major vessels before producing the symptoms like a pheochromocytoma. Pheochromocytoma, when they start, they usually present with the symptoms of headache and palpitation, and usually they are not that large as of the neuroblastoma. But of course, sometimes it's difficult if they both of them, and usually in our setting, we go for if somebody is having just a small adrenal tumor without any symptoms of like headache or flushing or palpitation, and if it's a resectable tumor, we just do the resection. But if it's a large tumor, we go for a biopsy upfront first and to see what is the diagnosis. In exam, should we write the SIOP or a COG protocol or both? No, you have to identify, you have to mention both the things, that these are the both approach, and briefly about that, what is the difference between the two. And then what you are doing, if they ask you how will you manage, then it depends that how you will do in your setup. If you are following the SIOP, you write the SIOP, but you have to mention these two protocols a little bit in your question, that what are the basic difference in these two. If following, Tahir Muhammad is asking, if following SIOP, after how much duration of a chemotherapy should tumor be reassessed with the imaging before going for surgery? Yes, I have mentioned that in the localized, you have to give the chemo for 4 weeks and you have to reassess the tumor by staging, because that's what the SIOP says. SIOP says in the local, you have to give the 4 weeks chemo, and the 5th week you do the CT scan, and the 6th week the surgery. And in the metastatic, you give the chemo for 6 weeks. On the 7th week, you do the CT, and the 8th week, you go for the surgery if they are resectable in the metastatic. Javeria is asking, books say we have to stop chemo after 6 weeks in case of a bilateral Wilms tumor if its tumor is not responding to chemo, and they say that we start with the 3 drugs to decrease the radiotherapy again. What should we mention exam? Yes, the same thing you have to mention. It's not only the COG, it's also the SIOP say that you give the 4 weeks of 2 drugs, and if it's not showing any response or any change, then you have to move to the 3 drug. But after 4 weeks, if you see some response, you continue with the more 4 weeks and you reassess with the ultrasound. You don't give to go for a CT scan every now and then for the radiotherapy, radiation risk. But after the 8 weeks, if there is not a significant change in the tumor size, then you need to proceed with the 3 drugs or a high risk chemo till the tumor is not possible to do the nephron sparing surgery.
Ma'am, there's one more thing I want to ask. That is, they say that if a tumor is not responding at all after 6 weeks, then either it is an anaplastic tumor or it has become well differentiated. So in both the cases, you have to go for surgery. And if it is responding, then you can continue chemo for 12 weeks. So
As far as I remember in a call, I mean in PSYOP, I'm very sure because we are for PSYOP, we do 4 weeks of three drugs. But what I remember from the COG protocol, they say that you can go for a chemotherapy till 12 weeks. But if they are not responding, then you have to do the open, and you have to do the open biopsy in the bilateral after 12 weeks in the COG protocol if they are not decreasing in size, to see is there an anaplastic or there is a maturation or a complete necrosis of that tumor. So you have to go for an open biopsy. Okay. Abdullah is asking, Wt1 gene also involved in adrenal development. So can Wilms and adrenal comes together? Yes, there is a possibility. The genetic tumor, I mean genetic mutation can do anything. I'm not the expert of the genes, but whatever I know is what I told you people. If bilateral Wilms tumor, Dr. Arshad is asking, if bilateral Wilms tumor and nephron sparing surgery is not possible, what about the renal transplantation? How much should we wait? Yeah. They are said that in PSYOP, according to the PSYOP and other things, that you should wait at least for the 2 years. Tumor-free after completion of treatment, you should wait for 2 years because majority of the Wilms tumor recur within the 2 years. Because if you do the surgery transplantation before and they are started on the immunosuppression, then there is a chance of the relapse. So 2 to 3 years is the time period which is needed to wait. And that is a problem here in our population because they already are so malnourished, and to be on the dialysis for 3 years is a big task. So that's why it's a problem to deal with the bilateral Wilms tumor. Pete surgeon is asking, is bone biopsy a mandatory thing in pre-op investigation in neuroblastoma? Definitely. You can't go for a neuroblastoma management without the bone marrow biopsy. Bone marrow biopsy is the mandatory in the staging workup. That's why I've said it's not only the aspiration, because sometimes the aspirations come negative and you have to do the bone marrow biopsy, and it's also the 2 sides, which is according to the protocol, you have to do the 2-side biopsy. If you are doing from the iliac crest, it's from both the iliac crest, aspiration plus biopsy both. You can't do the neuroblastoma management without that. Any other question? I can answer the only one more question if somebody has to ask one more question, or should I leave? Sharif, are you there?
Yes, Dr. Sadaf.
Okay. So I think they are not.
No more questions. Yeah, no more questions.
I think there are no more questions because whatever the present on the chat box, I have answered almost all the questions, and now nobody's asking any more. So if somebody wants to ask some more, otherwise I can leave. Should I?
So, yeah. Thank you very much, Dr. Sadaf.
Thank you very much. Thank you.